Hello, everybody. Thank you so much for tuning in today. Azeo Biologics is excited to host this webinar as a continuation of our digital education series. In today's webinar, Dr. Nayak will discuss his clinical review of CanGaroo envelope, as well as the histological analysis of prior implanted CanGaroo. Dr. Nayak attended medical school at Icahn School of Medicine at Mount Sinai, followed by his internship at hospitals of the University of Pennsylvania, Columbia College of Physicians and Surgeons. Dr. Nayak then completed his residency and fellowship at the hospitals of University of Pennsylvania, Columbia University Irvine Medical Center, and he is currently practicing out of the University of Chicago Medical Center, where he is the director of the Cardiac Electrophysiology Fellowship Program and their lead management program director. We have muted your phone lines for his presentation. However, if you would like to ask a question, simply use the text-to-chat feature in the top right-hand corner of your screen, and Dr. Nayak will address all of your questions at the end of his presentation. And so with that, Dr. Nayak, I'll hand it over to you.
All right. Well, I want to thank Liz and the folks at Azeo Biologics for inviting me to speak. I'm really excited to share some new information, especially the histologic analysis of an explanted CanGaroo envelope, to really sort of show everyone how this therapy or how this envelope can get enveloped into a pocket, and how this concept of having a healthy pocket is extremely important. So let's get started. And I want to thank everyone for his or her attention and being here today. These are the disclosures. The views here are presented in this presentation are solely of myself and the speaker, and I will share with you my opinions as how I manage patients. I do have some relevant disclosures. I have been given compensation for tonight's presentation from Azeo. And given that this is an extractor's perspective, I do have honoraria from Philips, which is a major manufacturer of extraction equipment. So what are our objectives tonight? So by the end of this presentation, you will learn the components and function of the extracellular matrix, or ECM. You will learn what the small intestine submucosa, or SIS, extracellular matrix is used for. You will understand why revascularization and regeneration is important for CIED pocket health. And just in case we have folks that are not familiar with some of the terminology, CIED stands for cardiovascular implantable electronic device. That's sort of the official name we give for implanted devices like pacemakers, defibrillators, or biventricular devices. And finally, the last objective is that you will identify which patients may particularly benefit from use of the CanGaroo envelope. So let's start off with asking a question. What is extracellular matrix? Extracellular matrix is the bioscaffold that makes up all the cells and tissues of our body. Every component of our body has extracellular matrix. Now, the following components are seen in the extracellular matrix. The extracellular matrix contains growth factors, which help with healing and regeneration. There's structural and fibrous proteins like collagen, elastin, fibronectin, and laminin. There's things called glycosamine aminoglycans and proteoglycans, which all work to kind of keep things in check and help with growth and regeneration. Now, the extracellular matrix, as I said, is ubiquitous, right? We see this throughout our body. But what do we use extracellular matrix for in medicine? So remember that it's a naturally occurring bioscaffold. And in all aspects of regenerative medicine, it has been utilized to restore and repair damaged tissue. So for example, when extracellular matrix is implanted in the body, our cells migrate to the extracellular matrix. And through a process of good remodeling, the extracellular matrix will turn into healthy tissue. Remember, one of the take-home messages today is that extracellular matrix is self, it's us, it's what we have, and the body recognizes it as that, as self. Now, extracellular matrix has been shown to modulate the host immune response to favor what we call constructive remodeling or good remodeling, rather than what we consider as an inflammatory response, for example, dense scar, heavy fibrosis. And often that type of healing is triggered by what we call synthetic materials. So any foreign body that's inserted into our body, it often elicits an inflammatory and a bad remodeling type of reaction. Now let's take a step back and go back to medical school, nursing school, or back to college when we talked about immunology, we talked about hematology. You know, what are we talking about when we say pro-inflammatory macrophages and regenerative macrophages? So we talked about the fact that extracellular matrix promotes what we call natural regeneration. And so that is mediated by something called M2 macrophages, or regenerative macrophages. They stimulate healthy tissue formation. They elicit what's called neovascularization, so the growth of blood vessels to promote good healing. And then that long-term tissue that's generated by the extracellular matrix is then incorporated and systemically connected to what's there. That's in contrast to, for example, a reaction where pro-inflammatory macrophages, those are the M1s, which stimulate inflammation, fibrosis, and often results in very, very dense collagen scar formation. Now I'm going to play a video here which kind of graphically talks about what we said. So let me see if this go ahead and works. Let me mute this here so I can talk over it. All right. So this talks about what the CanGaroo envelope is designed to do. So we have long-term benefits of what we call controlled healing. So with a typical device implantation, it's natural that complications occur, right? We see this clinically. Obviously, one of the complications is poor wound healing. Another complication would be, of course, infection. So currently, when you implant a device like a CIED, it is a foreign body. It is synthetic. So therefore, the body's natural reaction is to send blood vessels, monocytes, into that area and figure out, hey, what's going on in here? We see a foreign body. Now, these monocytes are the M1 variety. So they, of course, are ones that cause pro-inflammation. Now, that often ends up with a dense fibrous capsule. Now, what if we take a step back and say, well, is there something we can do to potentially mitigate that or prevent that from happening? Well, what if we use potentially an extracellular matrix? So the CanGaroo envelope is made of extracellular matrix. And when we use this envelope, in addition to placing the device within the envelope, when we place that envelope and the device into the body, we now are able to elicit a different type of reaction. And that is a reaction mediated by, as I mentioned, the M2 monocytes or macrophages. They, of course, help with regeneration. The monocytes also come to the area, but they transform into the M2 macrophage. With the growth factors, the elicitation of neovascularization, we now are able to incorporate that area where the device is sitting into the rest of the submucosa, into the mucosa. Neovascularization occurs, and we now have regeneration. So we have a healthy pocket as opposed to dense fibrous scar. So in essence, that's a graphic representation of this M1 versus M2 response. Okay, so what is SIS-ECM? So ECM, of course, is extracellular matrix. SIS is the submucosa of the small intestine of pigs. Now, the submucosa is found between the mucosal and muscular layers of the small intestine. It provides strength to the intestine and serves as a reservoir for cytokines that support the growth and differentiation of intestinal epithelial cells. So it is a bioscaffold that's found in the submucosa. The CanGaroo envelope is made out of the SIS-ECM, but it's decellularized during processing. So once that it's placed in the patient, it's not recognized as foreign material, even though it comes from the submucosa of the small intestine of the pig. In fact, because of the processing and decellularization, this ECM is recognized as self. And electrophysiology is not the only field that has been using SIS extracellular matrix. In fact, a number of branches of medicine, any type of medical procedure that requires regeneration and good healing, for example, facial reconstruction, corneoplasty, gastric bypass, ventral hernia repair, anal fistula surgery, all of those type of things use SIS ECM application. And in fact, to date, there have been over 3 million clinical applications. So you should take comfort in the idea that this is not something that's brand new. This has been studied, this has been utilized. Patients have had good results with this type of extracellular matrix. So what is the CanGaroo envelope? Well, we just learned that it's made up of decellularized SIS, submucosa of the intestine, and this is what is used to manufacture the envelope. Now, currently, the CanGaroo envelope is used with CIED implantation. It is an envelope that can accommodate a number of different sizes and shapes of a CIED. It comes in 5 sizes: small, medium, large, extra large, and one that actually will cover a subcutaneous defibrillator. And one of my case reports at the end of this webinar really shows you a picture of how nicely the subcutaneous generator can fit into this sub-Q envelope. Now, this envelope, the CanGaroo envelope, it's constructed, as I said, of SIS extracellular matrix. That in itself is rich in growth factors, structural proteins, collagens, all the good things that help with regeneration. It also supports this good remodeling that I talked about. It elicits neovascularization and then provides what we call the milieu for developing a healthy pocket for the lifetime of the device. So here's an example. Now, this is an animal model. This is a porcine model. So if you can see my mouse here, so here is obviously the outline of the patient's device. And this, of course, is the revascularization that we want to see. We want to see neovascularization in an area that's surrounding the device, because we want this area to be incorporated into the rest of the body. And this is kind of what it looks like. This is after 6 months after implantation using the CanGaroo device. You can see now, I don't know if there are any implanters listening on this webinar today, but when you do a generator change, many times that device is stuck into a dense fibrous capsule, and you have to use a lot of cautery to remove that device. And then many times, if to mobilize the leads, you are then using cautery over the leads, which in itself can cause potential damage to the leads. Wouldn't it be nice to have an opportunity just to kind of pick that device up from the pocket and have everything sort of intact without having any dense scar or dense fibrosis? Now, one of the other things that this biological material does, this extracellular matrix that's in the CanGaroo, is that it resists calcification. And we run into calcification a lot, especially in patients with chronic kidney disease and certainly end-stage renal disease. And that calcification on top of the fibrosis makes device removal and lead management very challenging. So why is a systemically connected vascularized pocket important to me? Remember that the rate of permanent pacemaker implantation, as well as ICD implantation, has increased over the past 2 decades due to a number of factors, right? Numerically, more devices are being implanted because there have been more indications over the last 2 decades. The average age of device recipients has increased. In fact, in one of the studies that I read, close to 20% of all new devices are being placed in patients above the age of 80. Because of that, the comorbidities associated with device implantation of our patients has also increased. We're implanting devices in a lot more diabetics, a lot more patients with heart failure, and in a lot more patients with chronic kidney disease. And all of these are risk factors for wound complication. Now, mitigating fibrotic capsules, for example, having the standard, dense fibrous capsule that develops over a device is not good, right? But by mitigating that, by trying to reduce that, we hope that we will have a healthy pocket, and overall, the device will sit better and patients will have a better result in terms of future generator changes. So here's an example of a very dense fibrous capsule. You can imagine that if you had to mobilize these leads to, for example, if you needed to revise them, or you needed to access them, or if you needed to reposition the device pocket or the device, this is dense fibrous scar. It's going to be difficult to get these leads out. You always worry about cauterizing over them. And this in itself is what we want to try to avoid. If we have the ability to use the extracellular matrix and we end up something like this, where that device and leads can just kind of slip away, slip off from that capsule, then that might be better. So once again, M1, bad, fibrosis. M2, regenerative, healthy, neovascularization. So which patients are particularly good candidates for the CanGaroo envelope? And this is my opinion. So certainly, I think any patient that is undergoing a de novo implantation, right? We want to start that patient's device history off well. We want to do the right things at the beginning of their implantation. And so if we can provide an opportunity to give that patient a healthy pocket, let's try to do that with using the extracellular matrix in the CanGaroo envelope. What if you have of those patients with, for example, known wound issues? So what do I mean by known wound issues? We all have seen patients who may be elderly, malnourished, they may have thinning skin, poor tissue turgor, excoriations over their body. We know that that is not healthy skin. That's not going to be healthy wound healing. Those type of patients are good patients to really consider using the CanGaroo envelope. Patients who have lost a lot of weight, maybe skin and bones, good candidates for the CanGaroo envelope. Hospitalized patients with chronic illness, right? They're probably often seeded with bacteria, viruses, been in the hospital, they've been ill, nutrition hasn't been good. Think about using the CanGaroo envelope in those patients. And then we've talked about the idea of things like diabetes, kidney disease, especially end-stage renal disease, anyone with an immunocompromised state, and certainly anyone who's known to have a previous infection. These folks are at high risk for recurrent infection. If we can provide a healthy pocket, that would be nice to reduce CIED complications. Now, switching gears a little bit, I'm going to talk a little bit about implantation from an extractor perspective. So as an extractor of devices, so device extraction, lead extraction, I've been fortunate to become a better implanter. And I think most of the extractors would agree that if we can remove leads, we kind of know exactly what we're dealing with. We've seen kind of how bad lead placement and bad device placement can make our lives difficult. All of us are now better implanters. So for the future person that's addressing this device system, he or she is going to have an easier time. We know that having scar in the pacemaker system, which means fibrosis, is directly related to the difficulty of extraction. The more fibrosis that you encounter, the more difficult it is going to be to remove the device and the leads. And in one study that was published a number of years ago, they found that device pocket scar was associated with difficulty of transvenous lead extraction. Remember, it's the vascular biology of each patient that dictates how much fibrosis is going to occur, right? And so if we can minimize that fibrosis somehow, potentially that's going to make our procedure a little bit easier to perform. So what have I learned over the years? So what I tell my fellows now is, number one, they're focused in on placing the leads well, focusing on making sure everything goes well with that. And it's easy to forget about the pocket, but pay attention to the pocket. Think about this and ask yourself a question. What can I do now that may result in a healthier pocket? So once again, providing a regenerative pocket, potentially by using the extracellular matrix, will give you that result. Number two, take a closer look at the skin and soft tissue of the patient. Really take a feel of what the tissue turgor feels like. Look for excoriation, saggy skin, redness, eczema, all of those type of things, because they're going to determine how this wound is going to heal from your device implantation. And specifically assess risk factor for CIED infection in each case. So the big risk factors for recurrent infection or infection would be previous infection, an immunocompromised state, poorly controlled diabetes, and I have a specific a case of that just recently, a gentleman who came in for device infection. We removed the device, and then 6 weeks later, we reimplanted a device on the opposite side, and that unfortunately got infected. And realized, unfortunately, a little late, that hemoglobin A1C was like extraordinarily high, like 15 or 16, and just he wasn't on any good medication. So poorly controlled diabetes is a big risk factor, and certainly chronic kidney disease and end-stage renal disease. I'm very, very excited to share with you some of this histologic analysis because I think it really takes, and in a visual form, really drives this message home. So let me show you this. So this is a histologic analysis of a new device capsule approximately 5 months post-implant. And so let me orient everyone to this slide here. So what's important to recognize here that this was a full thickness sample taken from the patient. Okay, so this was representative of the area where the device was sitting. So moving from, let's start from here, you can see my pointer. This single arrow represents where the device was actually sitting. So you can imagine that the device was sitting right here, okay? And then moving over, we can take a look at this thick arrow right here. This represents the outside of the capsule, and this is the rest of the, so you can imagine this is probably the pectoralis major muscle that's over here, and this is that capsule. And so what we did was this patient had a device put in a number of years ago, and about 5 months ago, the patient underwent generator change. And at that time, I decided to use the CanGaroo envelope. And so in a new generator, I placed a CanGaroo envelope and placed it within this capsule. And I did a partial debridement as well. And then 5 months later, unfortunately, the patient developed a lead complication. And so we re-intervened in that area. And I thought, gee, I haven't seen what the CanGaroo capsule, the CanGaroo envelope would look like after 5 months. And I thought it would be a good opportunity to send a sample of this out for histology. So that's kind of the background. So now let's take a look at these double arrows. Now these double arrows represent the pre-existing capsule that was there. Remember, this was a generator. The patient had had a generator in her device for a number of years. Why is this pre-existing capsule? Well, look at the dense, fibrous, organized collagen that's located right here, okay? And this is kind of nicely outlined in red here. And you can see the difference between this histology and, of course, this histology. Now, you might be asking, well, you told me that you used a CanGaroo envelope. Well, where is it? Well, that's the beauty of this. It has been incorporated into this pocket. So what we see here with the triple arrows are an influx of the mononuclear cells. So these are the monocytes that have now become M2 macrophages at some point. And you can see here, this is blood cells. This is neovascularization that's occurring. So this CanGaroo extracellular matrix has caused a healthy regenerative change to occur, but the CanGaroo envelope has just been incorporated into this nice regenerative area as part of the new capsule. Now, you might say, well, how does the CanGaroo envelope get these signals to kind of do this? It was up against a very, very thickened capsule. Well, that's the beauty of this. The CanGaroo envelope, the extracellular matrix, will get signals from the body to transform itself into a regenerative pocket. So one of the other things to think about now is, who should get a CanGaroo envelope or who might be a good candidate? Pay attention to patients requiring generator changes. You don't have to do a full capsulectomy in order to have the CanGaroo pocket do the good things that it does. I want to share with you some clinical updates. We are at the University of Chicago. We're also participating in a longitudinal study on the use of the CanGaroo envelope. But this is some interim data from the SECURE study. So the SECURE study's purpose was to assess the real-world outcomes of the CanGaroo ECM envelope in treating a broad range of patients undergoing device implantation. It's a prospective, multi-center, non-randomized study. So it's basically saying, all right, we put the CanGaroo envelope in a certain number of patients, what happened? So this is interim analysis. So 160 patients were included in this interim analysis, a mean of close to less than a year of follow-up. And if you take a look at the low rates of adverse events, the use of the CanGaroo envelope was associated with a very low rate of adverse events. So I think supporting the idea this is a safe thing to do. In terms of how it was utilized, the vast majority were utilized in de novo patients. That makes sense. We want to start them off well with their device history. About a third were around device replacement and revision. And I think the histologic analysis shows that that can still take place, that you can have a development of a healthy area when you use the CanGaroo. And only about 4.5% actually had a capsulectomy. And that's why the CanGaroo is used. You don't have to do a capsulectomy. In fact, in my practice, I don't do a routine capsulectomy in the vast majority of my patients. So I think the interim analysis taken with a grain of salt, it is just a non-randomized study, but it does sort of speak to the utilization and probably the safety of the device. Okay, case presentations, I think those are nice to kind of go over, and you might get a sense of why potentially use the CanGaroo envelope in these cases. So let's start with case number 1. This is one of my patients here. He was a 77-year-old man who had complete heart block. He presented for a permanent pacemaker generator change when the device reached electroreplacement indication. He reported that the skin and soft tissue around his pacemaker had thinned over the last year due to a 12-pound weight loss from a chronic GI illness. The outline of the generator was visible, as were the edges of the header. You can clearly see that here, right? You never want to see this here. We certainly don't want to see any skin fixation over this area, because that's bad news if we see that. Now, though, importantly, I did not think he had an infection, right? The patient was asymptomatic. It wasn't necessarily red, wasn't inflamed, the skin wasn't fixed or indurated, but it was quite thin. So his risk for poor wound healing was quite high. Poor nutrition due to a recent GI illness, weight loss with low BMI, and he's elderly with poor tissue turgor. The risk of erosion was high. And so in this case, I definitely had the patient undergo a generator change, and I used a CanGaroo envelope, and I did that to reinforce the pocket. And with at least 4 to 5 months of follow-up, he's been doing fine. The incision looks great. So he's done well. So good example of the idea of, all right, looking at that patient's risk factors for CIED complication. This gentleman is at risk for erosion, risk for poor wound healing. What can I do to help mitigate that? This is the next case. A 35-year-old woman with non-ischemic cardiomyopathy suffered a cardiac arrest and underwent a subcutaneous ICD insertion. 1 month later, she presented to our hospital with partial dehiscence and required total system extraction. Copious amounts of purulent fluid was encountered, and I unfortunately had to do an extensive amount of debridement to remove all the infected phlegmon. Now, once the wound was completely healed and she was bridged with a life vest, she was offered a transvenous defibrillator, but she adamantly refused. She insisted on having another subcutaneous defibrillator. Now, due to the extensive amount of debridement that I had performed, there was little to no subcutaneous tissue to create another pocket to house the new generator. So what I did was we made a decision to place the new SICD generator in an intermuscular pocket. And this case was done when we were just beginning to do intermuscular pockets. We now do those routinely when we put in a subcutaneous defibrillator. So an intermuscular pocket is a pocket that we create between the serratus anterior and latissimus dorsi muscles. And I utilized a CanGaroo envelope to securely hold that SICD in place in order to create a stable environment. And as I mentioned, remember that the CanGaroo envelope comes in a number of sizes. One of the sizes will accommodate a large SICD generator. You can see that here. Here's the SICD generator. You can see how nicely the CanGaroo envelope fits this SICD generator. And then what I do is when I place it within the pocket, I actually tack down the device through the CanGaroo envelope to secure it and keep it in place. So yet another example of how the CanGaroo envelope can be used to stabilize that device into a pocket. So I want to thank you for all your attention, and I hopefully were able to show you graphically and with some of the data that we presented the advantages and the concept of using extracellular matrix. So once again, thank you for your attention. I'll be happy to take any questions.
Dr. Nayak, thank you so much for a great presentation. I'm going to go ahead and transition to some questions that came in during your talk. We have a fair number, so I'll go ahead and get started. But the first one was, what was one of the main features of the CanGaroo that drove you to begin your utilization?
Great question. I think one of the things that makes the CanGaroo unique is that it is actually a natural product. It's not synthetic. And I've had experience with using extracellular matrix before. And in speaking with my surgery colleagues, talking to them, they've been using extracellular matrix for many, many years. So I felt comfortable with the idea of using something that's natural to help with wound healing.
Okay, great. The next question, from your perspective as an extractor, do you feel that the capsule impacts the long-term health of the pocket and potential future interventions?
Yes, I mean, we've all had situations where we've done generator changes and the device is just sort of socked in there. The pocket's heavily calcified. The leads are all embedded within this thick fibrous capsule. If I need to mobilize the leads, then it's just going to be a chore to get the leads freed. Then I worry about damaging the leads as I'm cauterizing. So in that situation for generator changes, it's a tough one. If I need to do a lead extraction, but I want to preserve one lead and remove one that's faulty, I want to make sure that I leave the good lead intact without causing any damage. Getting those leads mobilized can be a big issue in making sure that we don't damage any of the leads during that procedure.
Got it. That makes a lot of sense. So, and the next question, maybe you can elaborate a little bit more on what drove you to use the CanGaroo in the patient that we discussed today during the histology portion.
Yes, so this person had some had a thick fibrous capsule in certain portions, and I actually did a partial capsulectomy in some of those regions. But this person was also quite thin, and since I had recently been in the pocket, literally 5 months ago, I wanted to make sure that this pocket healed up well. I think the extractors in the webinar understand the concept that is, if you intervene on a pocket, every time you intervene on a pocket, you increase that patient's risk for infection and poor wound healing. And so we want to do everything possible that this person's wounds heals up okay, and that this person doesn't end up with a CIED infection.
Okay, thank you. So next question, for those of us who are just now beginning to use the CanGaroo envelope, do you have any specific implant techniques you find helpful when using the envelope?
Great question. So the envelope does need to be wet. I would recommend that you don't wet it too long, maybe wet it for about a minute or so, and then use it right away. The second one is pick the right size. Try not to undersize it because you'll stretch it. And so, the good news is you have 5 sizes to choose from. And in fact, I think the sub-Q one is the only one that's on the market that fits the sub-Q as a single envelope. And so just pick the right size.
Okay, thank you. And back to the fibrotic capsule, what do you believe the role of the scar fibrotic capsule plays in infection rates?
Yeah, it's a good question. So we have some data. It's more of sort of observational retrospective data on the idea that each time you do a CIED implantation procedure, whether it's de novo, whether it's generator change, especially within that generator change population, you are going to introduce some degree of bacteria. That's just natural, right? We're invading the space that was closed off. And then what the body tries to do is if it sees bacteria, it's going to try to close it off and prevent the bacteria from moving, growing, spreading. And we've realized that very, very thick fibrotic capsules, excuse me, might be a nidus for that bacteria colonization. And there was one article that was published, and I did cite it in the presentation, which talks about that concept. Now, what we don't know is whether or not having revascularization is going to mitigate that, right? We don't have that data yet, but it makes sense, right? If you can have a healthy pocket with neovascularization without that thick fibrosis, potentially, don't you think that it's going to provide a better environment for healing, regeneration, and potentially less infection?
Okay, great. And then in your opinion, why do you think it sometimes takes more than a year to see various infections?
It's a good question. I think it's a combination of a lot of things. Number one, it's the actual implant itself, the implant technique. It's also patient-related risk factor. Right? There's some patients that will develop, immunocompromised state down the road. There are some patients that, for example, may lose weight after the device implant, and there's maybe poor skin over the device, or you may lose weight over the device. We've all seen that clinically, right? You place a device in, 2 years later, that patient's lost 20 pounds. You go, oh my God, I see the device. I mean, I can see the outline of the device. What happened to you? Oh, I was very sick. I lost 20 pounds. So we see changes in skin. We see changes in healing. And so I think there's a lot of factors. So we do know that if you get a device infection, you have to look back a year. And if an intervention was done from the year that the patient developed the device infection, we have to assume that it was related to the actual procedure itself.
Okay, thank you. Just a couple more questions. So, one, what role could this healthy vascularized tissue play with shocking impedance versus scar? Do you see it impacting?
Yeah, good question. I've not seen that clinically in terms of a change in the shocking impedance. I can specifically mention the SICD. The shock impedance for the SICD is an issue, and a lot of the determinants are related to fat. So fat underneath the can or fat underneath the coil. In this case, since we're talking about the envelope, we're really worried about fat underneath the can. That's not been an issue recently, given the fact that we've been doing intramuscular implants. But I have not had an issue with a shock impedance value based on fibrotic scar.
Okay, great. Good to know. I believe you probably touched on this in your last discussion of your last case report, but we had this question in the middle of the talk. So, have you ever used CanGaroo to make your implant easier or facilitate your implant? So, for example, in situations where it's more difficult to anchor the device.
Yes, so I mean, one of the advantages of using the CanGaroo envelope that it is able to safely and secure that device into the area where you want it to be. So you can use it, and you can use the tie down sutures through the envelope, and so that so the device is sort of hanging on into the envelope as well as hanging on to the fascia with suture. So I have used that to sort of position the device where I want it. Sometimes I've tacked down all 4 corners of the CanGaroo as well, just so in the next couple of weeks that device doesn't move as much. So I have used it on occasion for that reason.
Perfect. Thank you so much, Dr. Nayak. So if there are no more questions, we will go ahead and conclude today's webinar. In the event that you have any follow-up questions, please feel free to direct them to marketing@azeo.com